Hello friends, today we will discuss about hypersensitive pneumonitis or extrinsic allergic alveolitis or about farmer's lung. So if we try to define farmer's lung, it is something like hypersensitivity pneumonitis or extrinsic allergic alveolitis is an immune-mediated inflammation in the walls of the alveoli and bronchioles secondary to the inhalation of certain types of organic dust, including microbes, which may include bacteria, fungus, or protozoa, including amoeba containing water in ventilation systems, animal or plant proteins, and several low molecular weight chemicals. It is due to T helper cell mediated delay hypersensitivity reaction to inhaled antigens. T helper cells 1, that is Th1, release tumor necrosis factor, interferon-alpha, IL-12 and IL-18, while Th17 cells release IL-17 and IL-21. IL stands for interleukin. Let's see, in these there are examples. So disease like farmer's lung, here source of antigen is mildly hay, and putative and antigen is thermophilic acetomycetes. Bird fancious lung, that is source of antigen here is avian dropping, most often dropping of the pigeons and parakeets, and putative antigen is protein in avian feathers. Then comes mushroom workers lung. Here the source of antigen is mushroom compost, and mushroom spores are the putative antigen. And then bagasosis, it is caused by the sugarcane dust, and putative antigens are thermophilic fungi and actinomycetes. Then malt workers lung, here malt barley is the source of antigen, and asparagus species is the cause of putative antigen. There are some other type of lung diseases which are mentioned in the chart, and the most commonly implicated bacterial cause is thermophilic actinomycetes, which are gram-positive filaments bacilli that produce farmer lungs. Now, what will be the clinical features? The most patients, about 80 to 95%, are non-smokers. Most cases occur following months or years of continuous or intermittent inhalation of inciting agent. Then clinical presentation can be acute, subacute, or chronic. In acute form, present as fever with chills, malaise, cough, and dyspnea occurring 6 to 8 hours after exposure to the antigen. Its peak at 6 to 24 hours and usually clears off within a few days if there is no further exposure. In subacute cases, appears more insidiously with cough, dyspnea, and cyanosis lasting for weeks or months. In a chronic form, it occurs as gradually progressing cough with loss of exertional dyspnea. Then clubbing may be present. Usually occurs in patients with continuous low dose exposure to the antigen and is clinically indistinguishable from pulmonary fibrosis due to other causes. Another presentation is acute exacerbation of the chronic disease, which occur without further exposure to the offending antigen. Complication of long-standing diseases are diffuse pulmonary interstitial fibrosis, pulmonary hypertension, and cor pulmonale. What will be the investigation that we will perform in such cases? So, blood examination reveals the raised ESR and neutrophilia, particularly in acute form. Eosinophilia counts and IgE levels are typically normal. precipitating antibodies against offending microbes present in many patients, but their diagnostic utility is limited. Chest radiograph may show diffuse micronodular shadowing. Later, reticular shadows due to pulmonary fibrosis occur. Computed tomography with high resolution shows ground glass opacity, poorly defined centrilobular micronodules, and mosaic attenuation or expiratory air trapping. When fibrosis develop, high resolution CT usually demonstrate reticulation mainly in the middle portion of the lungs or fairly evenly throughout the lungs, but with relative sparing of extreme apices and bases. Pulmonary function tests show restrictive ventilatory defects with normal FEV1 is to VC ratio, and a reduced diffuse or for carbon monoxide. In farmer's lung, most common pattern on PFT is obstructive pattern. ABG studies show low partial pressure of O2 and partial pressure of CO2. Other investigation to confirm the diagnosis include provocation test, BAL, and lung biopsy. Provocation test. What's provocation test? So in provocation test, appearance of a respiratory or systemic findings, especially fever 4 to 10 hours after exposure, leukocytosis, diminished diffusing capacity, diminished vital capacity, or both, increase radiographic abnormalities, worsening alveolar arterial oxygen pressure. Difference indicate a positive response. BAL typical shows an increase in the number of T lymphocyte, though some patients may show elevated neutrophils also. BAL lymphocytosis is present when lymphocytes exist 30% of all cells in non-smoker and 20% in current smokers. Most often CD4 is to CD ratio is generally below 1, which normal is 1.8, but it may be as high as 4, which is seen in patients with sarcoidosis. Lung biopsy may show chronic inflammatory cell and poorly defined non-caseating granulomas. In late stages, fibrosis is visible. Now, what is the treatment? Identification and avoidance of the causative antigen is the best treatment. Then oxygen therapy in severely hypoxemic patient, prednisolone 1 mg per kg per day orally for 1 to 2 weeks, followed by gradual tapering over the next 4 to 6 weeks. Corticosteroids hasten recovery from acute stage but have no beneficial effects on long-term prognosis. So these was all about hypersensitivity, pneumonitis, or extrinsic allergic alveolitis.